And so I think about that all the time. Like, is this within my scope of practice? Do I have the capability, the knowledge, education, and training to discern, as well as any other specialist, about what's going on for most patients with most problems most of the time? And the answer is, yeah, optometry has that. And we need to embrace that. And we need to embrace that as the comprehensive care model. And so I want to dive a little bit deeper into this and kind of use this as an example to try to clarify what we're talking about, and to make it so that if we can solidify the definitions we're using, then maybe we don't have to parse things into further specialization. Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today what I want to do is I want to talk about specialization. I want to talk about primary care optometry. I've talked about this before, and I think we are really missing the opportunity to define terms clearly. So I'm going to discuss this. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local Macu Health representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to macuhealth.com and use the coupon code podcast2024 at checkout for special discounts. All right, now as I think about this, my good friend and colleague, Dr. Kyle Clutie, sent me an email yesterday, and it was with an article from the Review of Optometry. And this, this podcast is not today's podcast is not intended to impugn the author of this article. I think there's just this misunderstanding with what comprehensive primary care optometry is. And I think articles that focus on specialization don't do a great job of clearly defining the terms of what we're talking about. And so I'm hoping that this episode discusses the terms. I'm going to use an example of a doctor that is mentioned in this article as a specialist, but I want to break down his billing trends. So actually, I have analyzed, so we've developed, as you know, if you've worked with us, or even if you haven't, if you've heard me talk about this, we've developed tools at iCode to be able to help analyze practice data. So what is a doctor actually doing? What are they billing for? What are they doing in their clinic? And that can help us, one, track KPIs so that if we're going to invest time and resources into making things better, we can know, did we actually make them better? Did we actually address the things that we were trying to do better? And so when we analyze those KPIs, I can know a lot about how a doctor is practicing based on those KPIs. And I'll tell you, this doctor walks the walk. But he is portrayed as a specialist. But he's not a specialist. If you look at his data, he's a comprehensive optometrist. There's no question about it. And he might not even realize that that's what he's doing. And so I got to tell you, as far as my history and my background, I have to maybe give my perspective on what comprehensive optometry does to my mentors. So, my dad, I practiced with my dad for about 14 years before he retired, and so I learned side by side from his ability to help inform me about how we should be taking care of patients. I think back, I've mentioned Bob Vandervoort on the podcast, David Cockrell on the podcast, one of my mentors. Many of my mentors. If we go back to my first year in school, and we always would joke about this, Dean Foster. He would always say, most patients, most problems, most of the time. And so, I think about that all the time. Like, is this within my scope of practice? Do I have the capability, the knowledge, education, and training to discern, as well as any other specialist, about what's going on for most patients with most problems most of the time? And the answer is, yeah, optometry has that. And we need to embrace that. And we need to embrace that as the comprehensive care model. And so I want to dive a little bit deeper into this and kind of use this as an example to try to clarify what we're talking about, and to make it so that if we can solidify the definitions we're using, then maybe we don't have to parse things into further specialization. And so this article, I'll put a link in the show notes. You should read the article. Kudos for Review Optometry for taking a deep dive into different avenues that optometry can go down. And this is not obviously to even call out that people shouldn't be specializing. I mean, of course, there's specialization that needs to be had within optometry. But there are problems with the idea that you can't offer higher levels of care in a primary care setting or a comprehensive care setting. And namely those problems exist that if you're outside of a large, Kyle Clutie lists he has a whole article on this, and it's worth reading. I will probably link to that article in the show notes today as well. And he highlights the problems, a myriad of problems with saying, in order for optometry to be, or this push for specialization in optometry, there's nothing inherently wrong with it for the sake of being wrong with it. But if you're outside of a metropolitan area, if we really truly specialized in the way of like, all I do is pediatrics, and I'm in rural Nebraska or rural South Dakota or North Dakota or even rural California, it is not it doesn't help our patients. It doesn't help enough of the patients that are around us. Forget about whether it supports the practice or doesn't support the practice. I'm not really interested in that. What I'm most interested in is, does it help the patients around my practice? Am I actually serving the population that I need to best if I think about my only value to them as being a specialist? So, in any case, let me dive into this a little bit deeper. And so the title of this article is Pathways to Specialization, Find and Follow Your Calling. And then it's a very lengthy article, and it goes into a lot of different specialties. And one of the providers so first of all, I want to show you a graph. If you're watching this, I'm going to show you a graph of how they parse out different specialties. And I think it's really telling because it breaks down. It's kind of a weird way to break things down. So if they look at like this, if you look at where students want to be after graduation, we sort of look at this as like 50% want to be in primary care, 47% want to be in primary care. Then we look at ocular disease, 18%. What is ocular disease? And then you look further down on here is like dry eye. Well, is that ocular disease? So they kind of separate dry eye from ocular disease. That's kind of a weird way to do it. A lot of patients, what's a contact lens specialty? Well, a contact lens specialty in many people's eyes is going to be things like orthokeratology, or it might be scleral lenses, or it might be RGP lenses. Well, a lot of people who have ocular surface disease might be also needing scleral lenses, and part of that specialty might need it. And think about, okay, well, if it's orthokeratology, are we talking contact lenses orthokeratology? Well, that's going to fall into pediatrics, but pediatrics also falls into vision therapy. And so there's these like weird categories that we're trying to like parse the profession down smaller and smaller into these subcategories. And I would look at this like, primary eye care, again, is managing the vast majority of your patients at a very high level, because there is nobody better than optometry to understand the nuances, both from a vision demand standpoint of a patient who has macular degeneration, and oh, by the way, they also probably at those age groups have ocular surface disease and meibomian gland dysfunction, and they may still want to wear contact lenses, which in this case is a specialty. And they may need other treatments like, at the very lowest end, punctal occlusion, and the very, more invasive end, they may need things like amniotic membranes and IPL or RF or LipiFlow or tear care, pick your widget. And there's nobody better than optometry to understand the nuances of all of that and to listen to the patient's vision complaints. And they might also need, they're in the same risk category of needing, glaucoma evaluations. And so all of these sorts of things come into play, but I can't just do that, because those patients have kids. And if I'm good at contact lenses and I'm good at scleral lenses, I'm good at RGPs, why shouldn't I also offer procedures for patients who need myopia management with orthokeratology lenses or other specialty soft contact lenses for those patients? And if I could do that, well, why can't I understand the evidence behind myopia management with medications? Is that a different specialty? And really, then it comes into you have new devices like NeuroLens, not really new, but we have NeuroLens that's sort of still ramping up, and those devices kind of uncover and allow us to manage one very specific binocular vision disease. But you're going to find that those patients that have symptoms that we can't fix with a NeuroLens also might need office-based vision therapy with home support. They might need just purely near ads or prism powers. So in order to think about these patients in these silos is really challenging. And so they go through this article and they talk about all these different specialists. And so I just picked one at random to see what their data looked like, what their Medicare billing data looked like. And I've become a little bit jaded with this because, I've had the pleasure of analyzing this data for guys that are spending time in practice grinding away, just taking care of patients, just doing a great job taking care of patients. And I love to visit these practices and help these providers with implementing new treatments and new protocols into their practice so they can continue to deliver really high-level care, really specialized care to these patient populations. And they do an amazing job, and they incorporate all of those care paradigms into their primary care practice. But it's not what Review of Optometry is thinking of as primary care. It's like, how many different ways can we say not for just prescribing glasses and contact lenses and soft contact lenses, So in any case, I see these guys out there really doing the work. And then I've also had the pleasure, I would say, of analyzing big names in our professions. I won't tell you who they are. There's some big names in our professions whose data is they practice what they preach. You can analyze their Medicare billing data, and they are doing what they say they're doing. But then there's others who are not doing what they say they're doing based on Medicare billing data. And so I decided I'd pick one of these guys or gals at random. And I did. It was just basically the first name I came upon in the article as I was scrolling back through it really quickly. And so I said, let me see what this guy does. Like, is he a specialist or is he a comprehensive care? Is he doing most things for most patients most of the time? And so let me share this data with you.
CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today.
One of the challenging things with patients is when they invest in a really high quality pair of glasses and customized lenses, it can be challenging to keep those lenses clean, keep them scratch-free, smudge-free. And so we now have the ability with Crizal Sapphire HR lenses to offer our patients the best-in-class anti-reflective coating in a way that is really high resistance so that they're not having to care for their lenses as much as when those lenses are caring for them. So remember that you can provide patients that best-in-quality, best-in-class transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal. If you're watching the screen, I'll narrate this as well, but if you're watching the screen, I'll dive into his data and I'll show you how I look at it to know how he practices and how I know he's not just a quote unquote specialist. He's doing most things for most patients most of the time. And so let me share this. So what I did was I exported this into a spreadsheet to do a few calculations. And I would butcher his name. You'll be able to see his name on here. First of all, if you see his name on the screen, kudos to this doc. And actually, I'm going to reach out to Harvey Hanlon because I suspect that he knows this doc and see if he can connect me, because I would love to interview him for the podcast. But I won't mention his name. You'll see it on the screen if you're looking. But he's got great Medicare data. So again, in one of our pieces of software that we use at iCode is an analysis of billing data for Medicare. Now, Medicare publishes this information, and there's, I can't remember how many millions of records, but basically we take this information and we upload it into our software, and then we ask it to find different providers. It's not just optometrists; it's all providers of any that are billing anything to Medicare, and we can find what those providers are billing, and then we can make general judgments about how they're billing things, and we can give specific recommendations to them about how they might want to consider different things. And then we're working specifically with a provider. So I don't usually use this data to call out a specific provider. It can tell me. I like it internally to know, who might be valuable, picking their brains about really like thinking about clinical activities because they've done it in practice versus they just are talking heads for that will be available to give really nice presentations, which is valuable, but it's not what I might want to know from them about their clinical practice. And so I use it internally with specific doctors to understand that, but also to do what we're going to do right here. But if I were going to work with a practice, I would actually look at their specific data, because what isn't included in this is the patients that are paying cash, the patients that are have private insurance, the patients that have Medicaid. It wouldn't be included in this data, but anything that would get run through Medicare data would be shown on this analysis. So whether or not that's Medicare Advantage or just straight Medicare Part B will be able. I can analyze these practices. The thing that I can't see in this is how many refractions that he billed, because the refractions aren't billed and they're not recognized, so Medicare doesn't report on them. So this analysis is slightly different than what I would normally do. I would normally have my denominator be the refraction, but in this case, the denominator is essentially the evaluation code, the office visit code. And what I'll show you, what you can see in this data is that there are, and I do have some insight related to kind of the billing patterns that I see here, but that's beyond the scope of this, and I would be happy to talk to this doctor about that. But I will kind of make some general observations. So if I were going to use, so first of all, they use two different types of office visits: a level 3 office visit that to Medicare, and then a comprehensive exam. Those are the only two types of office visits that are billed. And again, I have lots of thoughts about probably how we could help this doctor with those things. But again, beyond the scope of this, check out iCodeEducation.com. We have lots of billing coding resources. Comprehensive Optometry Simplified, that's what we do. But anyway, I had to give a little shameless plug. Okay, so when I look at this data, I'll use those office visits as the denominator. And if I add those two together, there's 520 in this one particular year. So now, again, there's lots of other offices that this doctor is probably doing, but to Medicare, there's 520. And a couple things I would look at right away is that this doctor is performing a wide variety of services. So a wide variety of different diagnostic services that tell me about the likelihood that they are managing conditions of the retina, of the optic nerve, of the tear film, right? So if I want to tell you this. So if you look, he has 50% of all of his office visits will have a fundus photo associated with it. 40% will have a corneal hysteresis determination, which is actually really interesting. He has I can tell you right away, he believes that corneal hysteresis is a valuable measurement for his glaucoma patients and glaucoma suspects related to their care. Okay, so 40% of them will have a corneal hysteresis determination. 20% of them will have a visual field test done. And what I really love about this doctor is he has not abandoned fields. 22% will have an optic nerve OCT. So they're going hand in hand. If he thinks that something is important to measure in the optic nerve OCT, he's also has not abandoned visual fields. And when we look at data often, for doctors who want to expand their glaucoma, one of the lowest hanging fruit is that they're not doing visual fields for a number of reasons. They're not doing nearly as many visual fields as their optic nerve OCTs. Well, this doctor is almost doing a 1-to-1 ratio of fields to OCTs, and that's a really great sign. One of the things I look at is, you hear me harp on clinical practice guidelines all the time. Our clinical practice guidelines recommend yearly, it's not Chris Wolfe talking, yearly gonioscopy. Well, this doctor does gonioscopy on 3% of his office visits. So he's 20% for his OCT, 22% for his 22% for his OCT, 20% for his visual field, but 3% for his gonioscopy. I think it's kind of easy to push gonioscopy to the side. The point is that what he's managing glaucoma. He's managing glaucoma patients and glaucoma suspects in those realms. Okay. Now, so we know he's doing photography as well, and photography is nice because it applies to both retinal disease, fundus photography, retinal disease, and glaucoma, right, and optic nerve disease, and other peripheral retinal disease or central retinal diseases. So he's managing a lot of that, and it makes sense. And he's also figuring out a way to split those up so that he is billing both of them when he wants them, and not just simply doing one and then writing the other off because he's done them on the same day. So he's figured out a way to plan his care out. And we help people with this all the time, to plan his care out so that if he wants a field and he wants an OCT, he gets them, and he also gets reimbursed for them. Okay. Now let's look at macula. Does this doctor? So we clearly know this doctor manages patients who have glaucoma, but he's also performing a retinal OCT on 9% of his patient population. Okay, so again, of the 520, 9% of them have some retinal disorder that he believes is important, for Medicare populations. And again, the prevalence of macular disease in patients over the age of 65, you would expect that some of those patients you're gonna want photos, some of them you're gonna want OCTs on. But 9% makes sense. So what that tells me is he's not abandoning retinal disease. He's managing patients who have retinal disease as well. Then what about anterior segment disease, right? Is he a dry eye specialist, or is he an ocular disease specialist, as this article tries to subcategorize these other categories? Well, look at his analysis of tear film. Okay, so he actually uses MMP9s and osmolarity tests. 23% of his 520 office visits get an MMP9 test, or he bills, and that could be double. He might be doing one for each eye. Okay, so that could be half of that, and I think that's probably what he's doing. I'll break this down in a second, but 23% of so he's probably billing two MMP9s, so one for the right eye, one for the left eye, but and then 12% of his patients have osmolarity measurements. So I think he's probably billing one if I were to see what he's doing, he's probably billing one osmolarity and then 2 MMP9s, because they're basically, the MMP9s are double the osmolarity. Now, he may not be. Maybe he's doing 1 MMP9 and 1 osmolarity measurement. And if that's the case, I'd wonder, why wouldn't he just do them both? He believes they're both important, but why isn't he doing them both on his ocular surface disease patients? But the bottom line of all of that is he's managing at least 12% of his patient population in Medicare age. He's managing actively. He's taking an active management of their ocular surface disease. So, if I look at this, and he's doing cataract post-op. So he's got, 4% of those patients are cataract patients he's doing post-op. So the whole summary of all of these things is, to me, I look at this and I say, this is primary care. He's doing most things, comprehensive care. He's not a specialist. And if he identifies himself as a specialist, that's fine. There's nothing wrong with that, in so much as, like, I'm sure he is excellent at managing patients who have all these diseases. And to the degree that that's a specialist, kudos. I believe it. I actually look at this data and I say he's walking the walk. But this article, I think the challenge for our new doctors that are coming into practice, for existing doctors that are providing care in all over the country, even in metropolitan areas, but more specifically in suburban and rural areas, the idea of specialization and the way that you can be maximally satisfied through specialization, I want to say you can do that, and you can also you can perform at very high levels. You can know what the experts are going to do in most cases for most patients by observing patients, by reading a whole lot, staying as up to date as you possibly can on research, and then having some confidence in your abilities to understand that the patient that while you're doing the refraction and you're observing that the patient reports that they blink and their vision has changed, and having a conversation about their ocular surface and taking an active role by following up with that patient on purpose with their ocular surface disease, by identifying the patient has anterior basement membrane dystrophy that might be causing symptoms of recurrent corneal erosion, because you ask the question during your normal slit lamp exam, because the patient who might be receiving injections for their wet macular degeneration, studies show us that they're going to be at higher risk for developing glaucoma because of the changes in intraocular pressure that occur with injections, with repeated injections. I mean, knowing all of those things and being the one that diagnosed their macular degeneration in the first place to get them to the retinal surgeon, knowing those things, that is primary eye care. That is comprehensive eye care. And the more we try to think about them as specialists, that's not my role. My role is glasses and contact lenses, and anything that I see that's not normal, that gets to the specialist. In my view, the real risk is that it makes us delay, it makes us wait until things become bad enough for us to get that patient out of the practice, get them out, because it's all of a sudden so bad. If you're the comprehensive care provider, most patients don't all of a sudden get bad. They kind of do so gradually. Their dry eye gets worse gradually. Their glaucoma gets worse gradually. Their macular degeneration gets worse gradually. Their corneal anterior basement membrane dystrophy, or their Salzmann's nodules, or their meibomian gland dysfunction, their Fuchs, get so gradually. They don't fall off a cliff in most cases. And so in my opinion, there's nobody better than however you want to define it, right? A comprehensive care optometrist, a primary care optometrist, an optometrist, a medical optometrist. Doesn't matter how you want to define it. It's all talking about the same thing. This is what optometry is. It's what optometry does. And there's nobody better to serve the vast majority of those patients, even at really high levels of care, by following what the evidence tells us, what new studies tell us, and experiencing what we're seeing in patients, taking some reflection on, why do we see this in this patient? Why did this patient respond that way and not this way? And also recognizing that specialists in certain areas, in fact, most specialists, they become specialists by simply focusing on those things in very specific ways that we can mirror as well. And we can have clinical insight, and we can know patient preference for treatment better than a specialist can, because we're thinking about all their things. And so in any case, I love the fact that this article was written. I love the fact that it allows me to kind of break down the way we think about comprehensive care, the way we think about primary eye care. But, and it's not to say that specialization isn't important and doesn't serve specific populations and optometrists shouldn't do it. That's not what I'm saying at all. It's just saying that we can't lose sight of the value of high-level chronic disease and acute disease management in the comprehensive eye care practice, because if we do, we'll be missing so many patients that could be served by our services. So I hope this was helpful. It was a lot of fun for me to break this down. Please write a review, share it with your friends. If you have something that you want me to talk about, if you want me to break anything down, I'd love to do it. Please reach out. I'll see you guys on the next one.
Hey, if you enjoyed this episode, make sure to subscribe to us on Apple Podcasts and our YouTube channel, both linked in the show notes. Now, here's something exciting. We're giving away a 1-year subscription to Comprehensive Optometry Simplified. All you have to do is leave us a review on Apple Podcasts, take a screenshot, and email it to me at questions@icodeeducation.com. We'll put that in the show notes as well. We'll be selecting a winner on December 15th. So don't miss your chance to get access to this valuable resource. Thanks again for listening. I can't wait to see your reviews.